So we're going to be talking about newly diagnosed patients who are typically not eligible for a transplant. And, a very important thing to kind of appreciate and understand is the fact that the majority of multiple myeloma patients are actually not transplant eligible. So you have at least 60% of patients who are above the age of 65. Having said that, the definition of transplant eligibility now is changing. We are transplanting people much older. The EMEA is also changing their definition. So the United States, we've always transplanted people as long as they were did not have any comorbid conditions, and as long as they were fit, we did transplant them. But typically, beyond 75, you tend not to transplant. So what does one do for that patient population? Well, there's enough data now to suggest that even in this older patient population, it's really important to try and achieve the best possible response. There's data now from the ALCYONE trial, which is more relevant to what happens in Europe, for example, where VMP has been used, that is bortezomib, melphalan, prednisone, in combination with daratumumab, and they saw a high incidence of MRD negativity even in patients above the age of 75. The VMP DARA trial really does not apply so much to the US population because we do not tend to use MP-based regimens. But the point I'm trying to make here is deep remissions are really important even in the older patient population, whether they're transplant eligible or not, and that's what's eventually going to translate into an improvement in outcomes and improvement in survival. So to speak to this, we had the SWOG trial, which is now published in Lancet last year, and what that SWOG trial did was these were not necessarily transplant ineligible patients, but they were transplant deferred patients. So that included younger patients as well. And what was done here was a triplet was compared to a doublet, the doublet being lenalidomide with dexamethasone compared to the triplet of lenalidomide, bortezomib, and dexamethasone. Again, the dosing of the bortezomib was a very conventional old-style dosing where we were still using the IV formulation. We were doing it twice weekly and so on and so forth. So toxicity was higher in the triplet arm, but nonetheless the progression-free survival was significantly better with the triplet compared to the doublet, and not just the PFS, but most importantly, the overall survival was even better. Now, given that we see an overall survival advantage, I do think the standard of care for a newly diagnosed multiple myeloma patient, as long as they're going to be able to tolerate this, should be a triplet. To this end, we've actually published now the RVD Lite schedule. This was published by Elizabeth O'Donnell, who's one of my colleagues at Mass General. And what she did very nicely here was in a phase 2 trial of about 50 patients, and these were all transplant ineligible patients, so a slightly different population from the SWOG group. Everybody got RVD, but in a very modified manner, where lenalidomide was given at a much lower dose, 15 milligrams. Bortezomib was given subcutaneously once a week, and the whole cycle was a 35-day cycle. So there was a 2-week off period between doses of lenalidomide, and this was extremely well tolerated. We had patients up to the age of 90 in this trial. And what Elizabeth found on this trial was a very high response rate with VGPR or better in more than 70% of these patients, and this translated into a really nice PFS and overall survival. Our progression-free survival median is about 35 months. The overall survival median is not yet reached. And at the same time, when you look at toxicity on this trial, we had very little in the way of grade 3 toxicity. There was just one patient who had grade 3 neuropathy. There was obviously a little bit of fatigue which required dose modification, but in general extremely well tolerated. So I think the default regimen, at least in the US, is a triplet now with RVD Lite in the older, less or more frail patient population, and they tolerate that extremely well. Can we do better than this? Absolutely. I think that's what the ALCYONE trial has taught us.